Hi everyone. Today I would like to talk about something that has gradually changed the way I think about full arch implantology. And that's the concept, what I call FP1 thinking philosophy. Some of you may know FP1 as a type of prosthesis, fixed prosthesis type 1. And I will explain in the next few slides what is the difference between the different type of fixed prosthesis. However, at first I would like to discuss FP1 as a mindset, as a prosthodontic way of thinking that influences how we plan, design, and execute full arch implant rehabilitations. Because in my opinion, full arch implant dentistry is not just about placing the implant or the prosthesis. It's about rebuilding a failing biological system in a most predictable and maintainable way. Let me take you back to about 15 years ago when I started my implant journey and the mission that I have with the FP1 thinking philosophy. Many of you will remember this, the 15mm rule, the restorative space that we needed for this type of fixed prosthesis type 3. That if we had less than this 15mm or 12mm space, we were bound to have prosthetic and biological issues. That was the study that was coming from studies from Carl Misch, Zarb, and so on. They came with these figures and we simply adopted, and it was perfectly acceptable way of thinking. However, every time that I came to show and consent my patients for treatment, I was really shy and conscious to show this kind of prosthesis to my patients, especially where the soft tissues, the abutments were visible, especially around the canines. And sometimes, if the technician was not very artistic in terms of developing the pink part of the prosthesis natural, it was showing really pink. It was quite off-putting. And we know that the patients did not really easily accept this. These prostheses were bulky, they were causing lisping, and we were telling our patients, oh, don't worry about it, you will get used to it. But worse than that, apart from gaining the restorative space, we were removing bone, we were removing gums, simple as that. Because the thinking philosophy was, we adopt the patient to fit the prosthesis. And we were thinking this is okay. For me, this is never really felt right. It never felt right that we are removing healthy bone. We were sacrificing soft tissues. Yes, many of the fixed FP3 prostheses and full arch cases that I have done up 15 years ago, they're still working fine. And we have an amazing implant survival. But the prosthesis, we have a lot of complications, and it's recorded in many of the studies from Boozer, Peterson, and more. Sometimes the rate of complication as high as 20, 30, sometimes 40%. Screw loosening, prosthesis fracture, fixture fractures, abutment loosening, abutment fracture, and more. More than that, we have issues with hygiene, whereas it's really difficult to lift the lip up and clean underneath the prosthesis. We have patients that are still complaining about how bulky the prosthesis is and how unnatural teeth are looking. Because of all of this, for me, something has changed. About 2013 to 2015, I think that was where the majority or the digital dentistry revolution has happened, or we call it digital dentistry arrival. With the evolution of the intraoral scanners, with the development of photogrammetry, we managed to create and build better materials such as zirconia, titanium, and so on. With development of AI and softwares, we were able to suddenly realize that maybe the problem was never the patient. Maybe the problem was our thinking. Anyhow, for those of you who don't know me, my name is Arman Barfeie. I am a surgical prosthodontist based in London. I run a clinic called London Dental Arts. We really focus on patients' well-being. We have a holistic approach to patients' treatments and overall well-being. Over the years, I have placed thousands of dental implants, and I have been involved in mentoring and lecturing. I have closely worked with Austin Dental Implants, and I run courses focused on full arch rehabilitation and 4D dentistry. Today, though, I'm not here to talk about myself. Today, I want to talk about a way of thinking. A prosthodontic philosophy that influences how we plan full arch cases. Because at the end of the day, patients don't want implants or they don't want prostheses. They just want teeth. Teeth that look, feel, and function naturally. And the closest that we can get to that in full arch implantology is FP1. We've known for over a decade from Peterson data that survival of the dental implant fixtures is predictable. But we've seen high complication or prosthetic complications that affect the longevity of the fixtures as well. So survival is not enough anymore. The goal is natural function and long-term stability. And that's where the idea of the FP1 thinking philosophy really started to evolve. Because ultimately, our mission is not just technical. Our mission is to change people's lives. And I believe the greatest professional satisfaction we as clinicians can have is when we restore something as close as possible to natural dentition. When we see that patient's cry of happiness, that's the ultimate satisfaction, at least for me. And that's what I do. There is a simple truth that sometimes we forget, that I'm gonna repeat. The patients just want teeth. They want second chances. They want a fighting chance to rectify what they may have not known in the past. So they want their teeth. And FP1 seems to be one of the solutions. If FP1 done correctly, it allows us to restore something that resembles natural teeth in contour, in emergence, in function, and hygiene. However, achieving FP1 outcome is rarely accidental. So it requires a completely different way of thinking. Let me show you a case, and by that I will explain the type of prosthesis. Here we can see in the photo above on the left an FP1 prosthesis and FP3 prosthesis and an FP1 prosthesis. These are both for the same patient. So this is the patient that came to see me. He had 2 years before he came to see me, he had an FP3 prosthesis fitted on 4 fixtures, or what we know, all on 4. He was very anxious and completely fed up with the screw loosening, with the way that the teeth looked, how uncomfortable he was when he was eating, and he thought he had really long teeth. But more so, he completely was agitated by the continuous screw loosening and fractures and abutment loosening and fractures with the way that the prosthesis was fitting. So FP1 prosthesis, what is FP1? Fixed prosthesis type 1 is when we only address the crown portion of the tooth. FP2 is between FP3 and FP1, is when we replace the crown and part of the root, part of the papilla. And FP3 is when we replace both teeth and the lost gingival and bone structure. And as we discussed, historically, many of the full arch cases were treated as FP3 by default. When I assessed this case during the planning phase, it was obvious that this case it should have been an FP1 case. But luckily, in this case, the bone was not removed to a significant level. By using digital planning, I added 2 extra implant fixtures in the posterior area. Around the implant abutment or the multi-unit abutment angles, I use photogrammetry technology. I have developed the soft tissues using a temporary provisional. I have restored the lower wound dentition, and I was able to give him a predictable FP1 prosthesis. And what is exactly FP1 thinking? FP1 thinking, as mentioned before, is a prosthodontically driven approach that focuses on 4 core elements. First, biology, prosthetic design, functional harmony, and long-term maintainability. These 4 core elements. In other words, before we place implants, we must already know where the teeth should be, how prosthesis will function, how the tissues will behave, and how the patient will maintain it. Only then we can decide where the implants belong. Let me show you another case. This is another case that was referred to me after the patient has gone to another clinic, and there were implants placed on the upper right, on the upper left, and lower left quadrants. He came to me because his implants were failing. But to this date, I'm still trying to realize what the implant dentist was trying to achieve here. I have overlapped the size of the teeth and the shape of the teeth that the patients actually liked after doing the smile design session with him. So we can see on the upper right that there is quite a bit of space between what the patients like to the available gum and bone structure. However, on the upper left, we see that there are some natural dentition. And then beyond the upper left four, there are no teeth again, and there is a defect in the jawbone. So whether we are going to restore the upper right hand side with a partial FP3 prosthesis, and on the upper left the same, but we never will be able to give a natural look that the patient can confidently smile, because if you look at the frame of his lips, the lips are opening and showing a lot of the buccal corridors. So aesthetically, at least, this is going to be a huge challenge. When I done the smile design for this patient, after showing multiple options including FP3, partial FP3, this is what the patients liked. So the question is not simply in this case, where do I place the implants? The real questions are, can we graft again? Should we reduce bone in this case? Or we should regenerate? What does the patient actually want? And is these expectations, are they achievable? And if we achieve them, are they going to be predictable? Equally important, am I, as Arman Barfeie, capable of delivering those expectations? Or I need to get other specialists and experts involved in this case? And these are real treatment planning questions. Here in this slide, another thing that we need to consider is the patient's affordability. Because FP1 solutions can sometimes require lots of hours of advanced planning. We need to do soft tissue manipulations, multiple provisualizations. We need to involve technicians who know the digital workflows really well. We need to be able to achieve passive fit from the outset. We must balance biology, technology, patients' expectations. So financial realities also need to be considered. We talked about digital technology and digital workflows. Here, I'm showing a case where we design options for an FP1 case in a platform called a Smile Cloud, which some of you might be available. There are many different systems available, such as Smile Cloud, DSD, and many implant planning softwares are available. But platforms like this, the real advantage of them, there are many, but for me, the improved communication between the dentist, the technician, and the patient. Because they can integrate all the data into one database, including facial analysis, smile design, prosthetic planning, jaw motion, and much more. So it'll become much more reliable to show the patients what we are going to deliver for them, and at the same time to be able to communicate with the technician more effectively. Because when everyone understands the final objective, the treatment becomes far more predictable. Implant and abutment position is one of the critical factors in full arch implant rehabilitation. Implant position, depth, diameter, the angle, alongside the abutment geometry, angle, diameter, gingival height, they all determine the emergence profile, prosthetic contour, and hygiene access and long-term stability. And therefore, it will directly impact the aesthetics and function. So implants should never dictate the prosthesis. It's the prosthesis that should be dictating where the implants need to go. Another critical concept in full arch implant dentistry and particularly in FP1 cases is the passive fit. If we have tension within the prosthesis, the system may not work. The passive fit has to be respected from day one when we fit the initial prosthesis, because the more stable the initial provisions are, the better the final outcome will be. Misfits could lead to screw loosening, prosthesis crack and fracture, material chipping, biological issues, bone stress, and many more complications. Recent studies show digital workflows and photogrammetry significantly improve accuracy compared to conventional techniques. Technologies like intraoral scanning, like the picture above, and extraoral photogrammetry have dramatically improved our ability to capture implant positions more accurately. And this allows us to achieve far more predictable passive fits in full arch prosthesis. Provisionals play a significant role in full arch rehabilitations. Provisionals are not temporary. They are the blueprint of success. Certainly in FP1 cases, the provisionals make a case a successful FP1 or a random, slowly deteriorating FP2 or FP3. Because they allow us to shape the soft tissues, the pontic sites, and emergence profiles in a controlled way. We can test aesthetics, phonetics, function, and many more. In fact, many FP1 failures are not just surgical failures. They are provisional failures. FP1 thinking philosophy allows us to develop natural, healthy emergence profiles. And to be fair, attention to emergence profile is one of the most overlooked aspects of implant prosthodontics. And maybe prosthodontics as a whole a specialty. Because prosthodontists think mainly only teeth and think less periodontics. We learned from several studies, many from Tarnow and his colleagues, that natural emergence influences aesthetics, soft tissues, tissue health, patient's comfort, patient's hygiene, and more. The paper by Boozer and his colleagues in 2017, the tissue stability concept, shows that correctly designed emergence profile will directly impact the longevity of the treatment and patient satisfaction in the initial and long term. When implants are placed correctly, tissues are shaped properly, we can achieve emergence profiles that closely resembles natural dentition. If you get emergence wrong, then everything else, unfortunately, will struggle. In this slide, this is one of the FP1 cases that I and my designer have prepared, and is perfectly demonstrating what we need to and we're trying to achieve. It shows the design of the prosthesis and the design of the soft tissues. I call this slide a perio-prosto interface because that's where the prosthodontics and periodontology truly meet. If we violate this zone, so if we don't respect this zone, complications will arise. Inflammation, bone loss, perimplantitis, mucositis will follow. This is why full arch rehabilitations must always be an interdisciplinary effort, whether it's from a single clinician who developed the skills both in prosthodontics, periodontics, and implantology, or a combination of these specialties together. Therefore, software such as SmileCloud, such as DSD and more, they become very useful in terms of communicating between the clinicians. Today, we already talked about how important it is to have a prosthetically driven full arch implantology. And this concept actually isn't new. It's from the 90s. Garber and Belzer already told us that the implant placement should be prosthetically driven. We need to know the prosthetic design before we start the treatment plan. The prosthesis itself must respect 4 main aspects. We need to respect soft tissue, occlusion, hygiene, and aesthetics. 4. A prosthesis that looks beautiful but cannot be clean will eventually fail. So prosthetic design must always prioritize maintainability. When we plan to design the final prosthesis, we must also plan for the design for the provisionals. Things that we need to consider is that, okay, the number of the implants, the APS spread, the distance between the implant fixtures, how it will impact the design for the provisionals, the definitive prosthesis. We need to know the quality and quantity of the soft and hard tissues. Once we carefully addressed and understood how these impact the provisional and definitive prosthesis, then we can have the whole idea of what the whole treatment is going to look like. We need to know whether we are going to go with the final prosthesis. Is this going to be cement retained? We know that there are some certain concerns about cement retained restoration, such as debond or excess cement causing perimplantitis, and several more. Are we going to go with more modern concept of a screw retained prosthesis? If that's the case, what's going to be the shape, the angle of the abutments? We need to know whether the final prosthesis, did we place enough number of the fixtures, what is the geometry of the abutments, and how are we going to finish with the titanium or metal bar type of a superstructure, and are we going to cover that with zirconium, with composite, with PMMA, with porcelain? We need to know what is the condition of the opposing arch. Are they worn down teeth? Are they heavily restored? Are there missing teeth? All of these will have a significant impact in the long-term stability of the newly done prosthesis. And I see many cases on social media, in my clinic, where patients done work elsewhere, where fixed prosthesis, implant prosthesis has been fitted, and the opposing arch was completely ignored. Another thing that I bear in mind for the prosthetic design is whether I am going to finish the case segmented or one-piece prosthesis. If we go with segmented, we like to believe that the prosthesis hygiene is going to be easier for the patient. There will be damage limitation and cost of repair will be easier and more manageable for the patient. But we have concerns about retention and longevity of the prosthesis with a segmented design. And sometimes maybe the bone, the soft tissue, does not allow us to go with a segmented prosthesis. So each approach has its own advantages and limitations. In my mind, segmented prosthesis should be prioritized and planned as priority. And if the bone, if the occlusion, if the technique and technology allow us, I think we should consider segmented over one piece. And there are studies to back up this as well. Another important and very underestimated aspect of full arch implant rehabilitation is the occlusion. Because unlike natural teeth, implants lack periodontal ligaments. They barely have shock absorption. So occlusal planning becomes quite critical. Nowadays, with using the jaw tracing technologies, we are able to analyze protrusive movement, lateral movement. We are basically able to analyze the dynamic occlusion, because using devices or jaw tracing devices like Mojo or Zebris and so on, we are able to obtain real-time motion data from the patients. Not only for this is not only for those patients who have temporomandibular joint disorders or TMJD. As we know, a significant percentage of population these days, they have measurable tooth wear and TMJD issues. I think according to certain studies, the rate is certainly above 50, and certain studies about 80% of population suffer from TMJD. Using the jaw tracing technologies, we have real-time vital motion data that enable us apply patient-specific design modifications to the provisionals and definitive, and the bite splints that we give to the patients at the end to ensure a more long-lasting outcome. Jaw motions are and should be an integral part of the FP1 thinking philosophy. So what actually determines success in FP1 rehabilitations? For me, it's not just one single factor. It's the alignment of several principles. We should be prosthodontically driven planning. We should have correct implant positioning, proper emergence profile, and functional occlusion. And that all of that can be combined in with an interdisciplinary communication. The effects. Let me show you an example here. This is an FP1 prosthesis, and in this case, the FP1 was supported by 5 implant fixtures. The teeth were removed initially. Immediately I loaded the temporary provisional on multi-unit abutments The final prosthesis is a single piece, multi-layered zirconia on tie basis. And I would like to believe that what made this case successful was not only the surgery. It was because I had the FP1 thinking philosophy from the outset. I took my time to plan the case and communicate it effectively with my dental CAD/CAM designer. We knew the final outcome way before the surgery. And then on the day of the surgery, once I removed the teeth in a traumatic way, I inserted the implants and abutment positions to the way that I already knew before the surgery. I knew the depths, the angle, the gingival heights, and all of that was hanging on in the surgery walls. So it was very easy, straightforward, 45-minute, an hour procedure. Once I've printed my initial provisional, I manipulated the soft tissues and carefully developed the natural gingival outcome and pontic sites. That's why the result was an excellent hygiene, natural aesthetics, and aesthetic soft tissue architecture. The final case for this lecture will illustrate the philosophy of FP1 thinking. The patient, as we can see here, she presented with a maxillary missing teeth with only maxillary canine remaining. On the first instance, it looks like an easy FP3 case because of the way the lip is positioned. So it looks like we need to remove maybe 1 or 2 millimeter or 3 millimeter or more for certain clinicians, depending on the restorative space we think needs to be available. We remove the canines and we will fit an FP3 prosthesis. But it will come at the cost of removing precious soft tissues and bone. Whereas what I'm really proud of this case is that when the patient came back and I fitted a segmented FP1 prosthesis, she came because of the lower FP3 prosthesis was rubbing against her tongue. But she loved the way the upper teeth looked. And she was making comments how the upper teeth looked natural. And interestingly, she did not have any pain from the upper teeth, and mainly some small discomforts from the lower. So let me finish this with these thoughts. Full arch implant dentistry is not about replacing teeth. It's about giving a deteriorating system another fighting chance. Implant survival is only the beginning. Prosthodontic success is the goal, but the real objective is the system rehabilitation. And with that, I would like to thank you for your attention and for your time. I would leave my email address here, and I'm more than happy to answer any questions that you might have. There is a QR code for my Instagram if you'd like to see more cases and to learn more about how we transform in lives. Thank you very much for your time. I hope to see you one day.